Dr. Mamula is a professor at Yale University in the medical school. His background is in immunology. He and his team has developed a very exciting new canine cancer fighting vaccine. I lost my dog Gus to cancer about 5 years ago, and he had surgery, he had chemotherapy, but unfortunately we lost him about 12 months after the diagnosis. And that's often true for many of these canine cancers, the aggressive forms of cancer. In spite of all the therapies, conventional therapies, the cancer does come back. And so it's extremely important to find new therapies that actually gives patients long-term, durable remission, which is equivalent, hopefully, to cure. So we were really happy and thankful that Dr. Mamula could join us today.
Thank you. I can say we already have something in common, Mari, which is unfortunate, but we both are parents of non-survivors. My own Labrador Retriever passed away from an inoperable tumor near her heart about 6 or 7 years ago now. And so, yes, the project, the program, and the therapies that we'll talk about today and in a few minutes are both personal and professional with me.
That's wonderful. And I'm so sorry to hear about your lab too. So can you tell us how the project got started?
So I'm an immunologist by training, and many of the successful cancer therapies in humans are based on training or reprogramming the host's immune system, be it the human's immune system or in our program, the dog's immune system, to attack tumors. So typically our immune system essentially allows us to survive all of the pathogens that we encounter in our lives. And that's many on a very daily basis, through skin, through breathing, through infection, viruses, bacteria, fungi, all sorts of pathogens that infect us and infect dogs. Our immune system usually protects us pretty well. There are a few exceptions to that. So our immune system's designed to primarily protect us from pathogens. But more recently, we and many other groups have identified a very capable, a very robust and strong ability of our immune systems to be trained, in simple terms, to recognize tumors and to hopefully attack them and stop growth or even slow their growth, or at best even reverse and eliminate tumors. So what we're doing is really based on the shoulders of many terrific medical investigators, cancer investigators, in trying to get our furred families' immune systems trained, if you will, to attack their own tumors.
Was your treatment tested with murine model initially?
Yes, absolutely. So my background is in immunology, and in particular autoimmune diseases that are characterized by an aberrant immune response to attack other self-tissues. These include diseases, notably things like rheumatoid arthritis, lupus, multiple sclerosis, type 1 diabetes. These are all diseases in where your own immune system attacks your own tissues. So we used what we learned from all of those diseases in initiating ways in mouse models to get an immune response against tumors. And again, this is an approach that's been thought of by many investigators, but there are many tricks to doing this, and there are many subtleties. If it were easy, the answers and the approaches would be solved by now, of course. So you're absolutely right. The best first model and the way that most human cancer immunotherapies begin are in mouse models of cancer. And yes, that's exactly what we did. We found a part of a tumor protein that I'll tell you more about in a bit, made a formulation that looks essentially like any other human, dog, or mouse vaccination formulation. We happened to pick the right protein, and not only that, it's the right structure of the right protein. As you and many know, these proteins are on the surface of cells, and they stick out from the surfaces, and they look like budding trees, literally, from the surface of tumor cells. We have to find the right branch of this tree to target an immune response to. So we worked out all those details in mouse models of cancer, worked out quite well, very well. We were able to clear mouse tumors very efficiently, prevent their growth, prevent metastases. But again, our strategy, our purpose is in not necessarily making mice healthier, but in making dogs and humans healthier, of course. So the project transitioned to studying canine cancers, cancers in our dogs. And it really happened by accident with me because I was originally very unfamiliar with the veterinary oncology community, the vast history that it has played in not only identifying mechanisms of canine cancers, but in contributing to how we understand human cancers as well. And I'll give you the short story, which is I was at a cocktail party and met a veterinary oncologist who happened to be treating a patient, a dog patient, who was the host of the party. And I had a fascinating conversation with him, and the timing was perfect. I had just completed the mouse cancer studies, and so we struck up a collaboration. This is Dr. Jerry Post from the Veterinary Care Center here in Norwalk, Connecticut. We initiated a trial in his facility for the first year and a half. It progressed quite well. I then applied and received permission to take this therapy to any licensed veterinary practice in the country. And we're now actively doing that with the social media circles, your own included. We've gotten a lot of visibility, a lot of access to many new patients, and it is really moving the program and our therapeutic strategies forward. We're learning a lot from every patient, what types of responses are important for good outcomes, what types of responses lead to poor outcomes. Those answers are just as valuable. If we know what works and what does not work in a patient, or what breeds of dogs this may be more or less effective in, what stages of cancer, where the cancer exists, and then, of course, really just the types of cancers. And we treat many different types of cancers, which I'm happy to go into as well.
So how long ago was this when you started the collaboration with Dr. Post?
The collaboration is now well into its third year, probably early fourth year by now. The formulation that we're using now has taken a few different, we've made a few changes to it to try and optimize what it does and triggering a vigorous immune response without providing, the side effects that some cancer therapies have. And I think we're now getting very close to having optimized what we now know will trigger a very active and robust immune response. And we've studied these things very carefully. We now know from very carefully done studies in the laboratory, Dr. Hester Doyle in my laboratory, if I can give her appropriate recognition here, is a terrific immunologist as well. We have taken tissue samples from many of our patients and asked, are the immune responses that we seek, are they finding their way to the tumor? Are they invading the tumor? Are they causing tumor cell death? The answer in many cases is yes. So we haven't talked about this yet, but maybe I'll just go into really the basics of how the therapy is initiated and how we expect it to work in patients in which it could be successful. So the therapy is really very simple. It is a vaccination, actually 2 vaccinations that are 3 weeks apart. It's a subcutaneous vaccination, much like any other canine vaccine.
So it's not injected into the tumor, but somewhere
That's
under
correct.
the skin. Mm-hmm.
It's not injected into the tumor. Of course, many tumors are not accessible, even if one could, get to them. So the practicality of that type of approach is a little different than what ours is. Ours is a very simple subcutaneous injection in the neck of the dogs, which is where these vaccinations always happen. It triggers a typical antibody response made by lymphocytes in the dog. This happens over the course of the first 2 to 3 weeks. And this is the same as human vaccinations as well. It takes humans about 2 to 3 weeks to make an active immune response to a vaccine that we receive as well. The dog will continue to make, and the levels and the amounts of these antibodies will continue to rise. And the dog receives a second vaccination, which we believe even boosts the response further. We hope then that the antibody responses will track or will find their way to the tumor, invade the tumor, and block the receptors that are on the surface of the tumor. And these receptors are very important for tumor growth. So just like in human cancers, where immunotherapies are very important, cancers grow by receiving signals at the surface, growth signals, allows them to multiply and get larger. So if our antibody can block or turn off those signals, the tumor has no signaling that allows it to grow. And in fact, it dies if it doesn't get signaling through these receptors that are bound by the immune antibodies that we're able to trigger in the dog.
These are the EGFR protein receptors that you find in overabundance on the surface of tumor cells.
That's correct. This is a family of 4 different proteins on tumor cells. It includes EGFR, also known as HER1 in some studies, and 3 other proteins, HER2, 3, and 4.
I think HER2, a lot of people have heard of because of breast cancer.
Absolutely, yes. HER2 is famous for being on a subset of human breast cancers, and they're also on canine breast cancer cells as well. These proteins are on a number of other human and canine cancer types, including adenocarcinomas, transitional cell carcinomas. We have dogs with anal gland carcinomas. Osteosarcomas are thought to have these proteins expressed. Hemangiosarcomas are another large group of canine cancers that express these proteins. So again, the important thing is that these families of tumor proteins are growth factors for tumors that we want to turn off. And then the other mechanisms that can help eliminate these tumors are the fact that other immune cells are attracted to the tumor as well, and literally choke the tumor off from being fed and nourished by the vasculature and by nutrients. And then the same ways that immune cells will kill off a pathogen, say a virus-infected cell, we hope that they kill off the tumor cell.
So not only are the antibodies getting created to go after the tumor cells, but the T cells,
That's correct.
cytotoxic killer T
A
cells are also being activated to come
Yes.
after the
A subset of white blood cells, lymphocytes, are called T cells, and even a smaller group of that are called killer cells, also known as CD8 cells. In the tissues that we've been able to study from our dog patients, we do see these killer T cells also infiltrating the tumors. And again, these are very important in eliminating tumors and preventing their growth.
I see. Now, healthy cells also have EGFR proteins on the surface. So how come the vaccine doesn't activate the immune cells to go after healthy cells as well and produce side effects?
Well, you ask a very good question. The strategy here is that normal healthy cells express significantly less EGFR and HER2 proteins than do the tumor cells. In addition, it appears that the EGFR family of proteins don't provide the same growth signals and essential survival signals to normal cells that they do in cancer cells. Potentially the reason that cancer cells overexpress these proteins is that the signaling through them is really much more essential to their growth and to their replication than is the case in normal healthy cells. So, but that's a very good point. We fortunately do not see side effects to other normal tissues, and we have looked very carefully. We've looked in brain and lung and liver, kidney, pancreas, skin, many other organs, and we don't see the same immune responses in any other normal tissues that we do in the tumors,
I see.
which is
And
good.
how many patient dogs have so far been treated with this experimental
We're
vaccine?
now probably in about 400 patients nationwide. The largest fraction of those patients include the osteosarcoma tumor groups, in part because those are the most frequent in the canine population, generally speaking. We have many hemangiosarcoma patients. And as I mentioned before, other patient groups, we have our transitional cell carcinoma. We have some lung cancer groups. We have some glioblastoma patients. Those tumors also express EGFR. We're assisted in many of these studies by knowing the biology of human cancers when it may not be perfectly known in dogs. Since most of the medical research is done in mice and humans, unfortunately, less of those studies are done in dogs, so we tend to know a great deal about the expression of these proteins in human tumors. We try to translate what we know about these proteins and their mechanisms in human tumors to our canine population, to our dog populations. And virtually all the time they translate very well. The same factors, the same growth factors and features of human tumors often translate to canine cancers. For example, the same features of osteosarcoma in dogs are true for those same osteosarcomas found in humans. The growth features, metastatic disease to the lung is the primary cause of morbidity and mortality, both in dogs and in humans. Many of the same growth factors exist between these two tumor types. The pathology is essentially identical. So there's really a lot of crosstalk between what we know about human cancer biology with what we now do in dogs.
Can you tell us about the fraction of dogs, number of dogs who have responded with longer term survival than, say, traditional chemo or surgery?
Those are great practical questions that everyone wants to know. We're writing up these studies for publication right now, but I'm happy to tell you that we've carefully compared vaccine therapy along with conventional standard of care. In our largest group of patients, which I mentioned is osteosarcoma, standard of care is often amputation followed by chemotherapy, typically carboplatin. When one adds vaccine therapy to that regimen of standard therapy, 12 and 24 and 36-month survival is approximately double of what studies find in conventional therapy alone. And that would be amputation and carboplatin. So by knowing the literature and how these cancers progress in dogs, 12-month survival in osteosarcoma is in and around 30 to 35% in most dog populations that have been studied. Adding vaccine, and this is with standard of care, adding vaccine to that regimen increases 12-month survival to about 60-65%. So to us, that's terrific. And to the owners, that's terrific. Twice as many dogs are surviving a year compared to standard of care. We're trying to understand what separates that 30% more that survive versus the other dogs that may or may not survive. And we're also, of course, trying to understand our failures. Why do some of our patients not survive 12 months?
Right.
Is it because of the stage of the disease or the degree of metastases or where the location of these metastases are, or other things like genetics of the dog, age, gender? Are there any underlying medical conditions that exist in the dogs? And again, all of these factors are considerations for how and why humans may do well or not do well with various therapies as well.
Yes, that's right. Now, I had a chance to speak with several of the dog owners of the pets who are doing very well. Ranger, Cody, I think Ranger, his cancer had metastasized and it was very large in his lungs, and that's disappeared. Also, Cody is now, I think, almost 3 years now after his treatment, right? And he's doing really well. So it's extremely exciting. And I think since you've only started 3-4 years ago, I'm sure you're continuing to collect the data for how long some of these dogs are going to survive. And it seems like you have this long tail of dogs who are doing extremely well.
Well, you mentioned the two poster children dogs. They're not child dogs, they're poster dogs for our therapy, which have done, very well. And we fortunately have very good objective imaging. We have the studies very well characterized between these two, and actually now a growing list of other dogs who have done very well in having either CT or X-rays over a nice range of time in which they've been having their disease. So yes, in one case, I always hate overstating what our vaccine can do because, again, we don't cure cancer in every dog. We try to, but we don't. These are a handful of cases that have done very well with objectively very significant, very severe disease when they were given the vaccine. And they fortunately have done very well. Yes, their lung metastases appear to have resolved. And there's nothing that tells the story better than a good X-ray that shows a mass in the lung and disappears after 3 months or 6 months. And the dog is surviving and thriving, doing well. Appetite and energy all back. That's exactly what we're trying to develop here, and gives us a lot of hope that we can potentially optimize this therapy for, more and more patients and understand the features of the disease that allow us to cure it.
Now,
So yes, they've done very well.
Are you collecting the tumor samples and analyzing the tumor samples to see if you can correlate the survivors, the responders, with greater expression of EGFR?
Yes, that's exactly what we're doing. We're acquiring a growing list of tissue samples. Now that we're able to access many other veterinary practices in the country, and as more veterinarians know about our work and are now referring new patients to us, and those are new patients among, say, a single practice, and we have a number of practices around the country that have um, allowed us to study. Literally, in one practice, we have probably 20, 25 patients. So when a particular practice knows the outcomes of what we can potentially do, and we can start to now think about how to optimize this therapy. So for example, in osteosarcoma, I've been trying to promote the idea that one should be vaccinated with our therapy prior to chemotherapy.
Mm.
The reason that is that chemotherapy can take up to 4 to 6 months to complete. And during that 4 to 6 month time, there's no active immune response against the tumor.
Mm.
Our immune therapy can be initiated and active within 4 weeks, not 4 months.
Mm.
So within a 4 to 5 week period of time, a patient can have an active immune response that's hopefully attacking the tumor. You can start chemotherapy, and the immune response will stay robust, will stay active throughout that period of time when the dog is then getting chemotherapy. So there appears to be good rationale, and I've discussed this now with a number of veterinary oncologists who tend to agree, is that in the absence of significant metastases and other underlying conditions, that maybe we should be vaccinating dogs before they actually get chemotherapy. And so we have a group of those patients, and you brought up the topic, well, how can we better study the survivors? Well, if more dogs are surviving, if we can boost that 65% 12-month survival to 70 or 80% by giving vaccine earlier in disease, we've learned at least one thing, is that early treatment works better.
Yes, yes, absolutely. Now, do you also have the ability to analyze and look for other antigens, other proteins on the tumors that you're getting?
Well, yes, you bring up another point. So we get the other point I neglected to say about having really a widespread ability to recruit patients is that we can proactively get tissues, so that if, say, a hemangiosarcoma, a dog is going in for surgery to remove a hemangio, we can get that tissue pre-treatment. We can see how much EGFR or HER2 protein is expressed on it, and other features about what's called the tumor environment, the tumor microenvironment. So we can see not only individual proteins on cells, we can extract DNA and RNA, we can look for mutations, we can look for other proteins, we can look for other immune cells that may be in the vicinity of the tumor. And so we're doing this both in osteosarcoma and hemangio and a few other tissues that we're able to get as well. This tells us a lot about, again, tumors that may respond versus those that may not respond.
So it might be in future possible to combine this with a different kind of vaccine that targets a different antigen that's overexpressed?
That's absolutely correct, yes. In fact, I would envision this therapy or vaccine therapy to be used as an adjunct therapy to what is now known in humans as checkpoint inhibitor therapy. You almost can't miss this topic of cancer therapy because advertisements for many of these human drugs will be in the middle of your nightly news broadcasts. So if you pay attention to many of those health-related advertisements that tend to tell you about all the side effects of immunotherapies, those are actually terrific therapies in humans that have not yet been fully exploited in our dog populations for cancer therapy. But undoubtedly will be in the next year, perhaps year. So we hope that both our therapy and other new therapies, either that we're able to develop or others regarding immune-based cancer therapies can work together.
Mm-hmm.
So that's where the future, I think, of both. We're very happy that our vaccine appears to be improving the objective outcomes and survival of our patients, but we always want to do better, of course.
Yes, yes, absolutely. Combining the vaccine with checkpoint inhibitors, that would be very exciting. Though I have not yet seen much data on checkpoint inhibitor work, even though I do know several labs are working on it.
Yeah. We're testing these strategies in mouse models because we now have our vaccine therapy, worked out in mouse models. And we also have checkpoint inhibitor therapies worked out in mouse models. So we actually can look at this before it gets to the point of being tested in dog populations. So.
Oh, that's fantastic. Can you comment also on how you think the vaccine differs from autologous vaccines made from dogs' own tumors, which some researchers are looking at?
There are other strategies that have been used both in human and in canine cancers, and that is taking a cancer tissue and making an extract of the proteins that exist.
Maybe you need to pick.
So these have been tried, and in fact, it's been tried in melanoma, and it's been tried in other tumor types as well. And there appears to be some success in doing that. The strategy is a bit more difficult because it actually requires having viable tumor tissue delivered in a timely and efficient manner to a laboratory that can process it in a particular way, has the skills to do that. So I suppose one of the advantages of our strategy is that it is potentially more achievable in more geographic locations. So for example, if a particular practice cannot get the tumor tissue, or if there's not a surgical practice linked to the oncology practice and can be efficiently processed and sent to the vaccine maker, this will be very difficult in many outlying communities, that really just don't have the opportunity to do
logistics this. And just having the vaccine there at the vet practice.
Yeah, there's just logistics that make what could be actually a very useful therapy. It just makes it difficult to apply to large populations of cancer patients.
So I do have a question about autologous vaccines. And you mentioned that with your vaccine, you carefully chose the peptides or the structure because EGFR, HER2, any of those proteins are very large structures. So you have to choose very carefully on what you're going to give the dog and turn into vaccine. But with autologous vaccine, you're not doing that. You're just taking this tumor and then hoping that there will be some mix of proteins that you could give dogs, and then the immune system gets boosted. So is it possible that some of those proteins may actually suppress immune system as well as activate, or what are your thoughts?
Well, you bring up sort of the dirty little secret of what that type of therapy may do as well, which is the strategy of this relates to how we treat allergic diseases, allergies. Our children that have allergies, we treat with the protein to which they're allergic to in small doses, right? So continuous small doses of something that a child or an adult is allergic to can help tolerize, can suppress an immune response. It's called immune suppression. So you're absolutely right. There is a risk of creating immune tolerance, turning off an immune response to a particular tumor protein by giving incorrect amounts of that tumor protein autologously And if the formulation is not perfect to actually activate an immune response, it may turn it off instead. So I'm sure those studies are underway to try and avoid those tolerance issues, but the manner in which our tumor protein is administered to the dogs only creates an activation signal because of the other parts of the formulation that we add to it. There's not really the chance to create the same immune tolerance that one might do with other vaccine strategies.
I see. That's a really very, very good explanation. Have you seen with your patients mutations with cancer so that EGFR expression disappears? So,
well, you bring up a good point again that we're presently studying. Humans and dogs will oftentimes fail a therapy because of the dynamic nature of tumors. An individual tumor has many different cells, of course, hundreds of millions of cells, and each of those cells can express different amounts of this EGFR protein or HER2 protein. And even as the tumor grows and gets larger, the tumor is a very smart environment. The cells that survive know that if they maybe shed some of these proteins and in the next generation of cells express different combinations or different amounts, it may allow them to survive better. We have to realize that a tumor really is trying to survive. We don't want it to, but it's trying to change, mutate, and survive. And all of those factors contribute to both human and canine cancers failing the therapies that maybe initially worked quite well, but they mutated or they changed or they lost EGFR or they rearranged EGFR with other proteins on the surface. And this is all to avoid being killed by a particular immune therapy or a chemotherapy. So you're absolutely right. This is a very dynamic process. And in fact, we hope to learn how dynamic it is, both in the survivors and in the non-survivors, if we can, by getting tumor tissues.
are you getting tissues at different time intervals?
Yes. In limited circumstances, yes. Okay. So for example, if there's a metastases or a second surgery, we're sometimes able to get second tissue samples from the same patient. And it can tell us whether it looks like the primary tumor or whether it has changed and mutated. And again, we can do this by looking at all the same things, the tumor proteins, the RNA and the DNA that are in all of these tumor cells, the other microenvironment. Are there more immune cells there? Are there fewer? How is the vasculature within a particular tumor? So all of these things give us answers.
So one of the things that fascinated me about the way you're running the clinical trial is that your inclusion criteria is not overly strict. It's quite open. So yes. A dog in stage 1, 2, 3 with various treatments, a dog with even metastasis could actually receive your experimental treatment.
Yes.
And compared to traditional clinical trials where they are very, very strict about, it's a dog who's only undergone this kind of treatment and it's this type of cancer. And I was wondering if you could mention the pros and cons of your approach.
Well, that is a very good point about our own clinical trial. We feel like if we acquire enough patients in a particular group, for example, you bring up patients with metastases and without. That's a very important distinction for us. And I want to know if our vaccine strategy helps either one of those patient populations individually. And then if we don't have the patients to begin with, so for example, if we exclude all patients with metastases, saying we're only treating patients with primary tumors, that's the only group we will know about. Having both groups we'll know the answer to whether our therapy is effective for distant metastases. And it will also help us understand whether the therapy prevents metastases in that group that did not previously have metastatic disease.
Mm-hmm.
So other groups I can tell you about as well. We take on patients that have failed other therapies, either chemotherapies or other immune-based therapies. That tells us whether our particular immune strategy is different than one that has already failed. And that's important because we have a very different part of the tumor protein that we're using for our vaccine compared to any other. That's what's unique about our therapy. I hope to prove that it's a good therapy, of course, relative to others. But if we have serum and tissues from other patients who have failed a particular therapy, failed chemotherapy, we can know a lot about the tumor environment that failure has occurred and know whether we can overcome it with our vaccine. So that's why, as you point out, that our inclusion criteria seems fairly relaxed. I would say that it's actually fairly strict because we are very careful about taking all of the particular clinical information from an individual patient and carefully putting all of our patient groups into the categories that will look similar. So 100 patients have failed carboplatin. So we put them on our therapy. 100 patients have not had carboplatin, maybe doxorubicin, or maybe they've had both or neither. Our therapy, what does it do? Even patients on various supplements. There are many supplements that are potentially quite effective in treating cancers. So we take careful records of all of our patients that are on supplements or not on supplements. And these can be herbs, CBD oils. We take very careful patient history. And we will eventually be able to answer the question, does the vaccine help in conjunction with these other potential therapies or not? Is the survival, is 12-month survival better with various herbal supplements plus vaccine, with or without chemotherapy, or not?
Yes.
And these are all questions we hope to answer.
Yes, that is very good because, in many of the other clinical trials, you're talking about 20 dogs, 30 dogs, very low number of dogs, and you just can't learn as much as you're learning today. Now, is that kind of approach being introduced into human clinical trials too, or not?
I happen to be part of a human clinical trials program here at Yale University, and we're honestly trying to pattern how we approach this in dogs to what I've appreciated as informative patient groups in humans. And this is the manner that I was just describing, which is in being able to collect enough patients in numbers to be statistically meaningful. And in humans, this could be other factors, including age groups. So for example, we can take osteosarcoma in humans. Of course, it's mostly a disease, a cancer of the youth, but adults can get this. But the question is, does a particular therapy affect patients of 5 to 10-year-olds or 10 to 15-year-olds or 40 to 50-year-olds? These are how human clinical trials are performed. Do the outcomes look different in those patient groups, male versus female patients? This is clearly important in dog cancers, particularly in some of the more hormone-driven cancers, breast cancer, for example. Cancers that have estrogen receptors are clearly have different progression in males versus females. So there are a number of factors that, while it may seem that some of our outcomes or our strategies may be diluted because of so many variables, we're trying to do a good job of carefully categorizing all of these patients, knowing exactly what they've taken and what they've used previously, what they've failed previously, or what's succeeded.
Excellent. Now, are you going to be taking your vaccine through the approval process so that it could actually be commercialized and marketed?
Yes.
Or, yeah.
Yes, that's our goal. It's one of our goals. My more immediate goal in being both a dog lover and owner, I have 2 golden retrievers presently, is that, and as I mentioned early on, is that this is both a professional and personal interest of mine, is that my goal is to get this on every veterinarian's shelf as a therapy for these cancers. And we're writing up the canine work right now. We're analyzing all the data that we've been discussing and trying to understand the patient groups and make meaningful conclusions from what our therapy has done. And then we're going to seek approval as a veterinary product.
Excellent, excellent. And so this question is something I'm very curious about. Affordability. Today, as an experimental treatment, there's a suggested donation to the Yale University for about $1,000. But as a product, what do you think is it'll end up costing?
Oh gosh, you know, Mari, I'm a terrible business person. If it were up to me, I'd give it away for 10 cents. If it were up to the business people, either here at Yale or elsewhere, I suppose, I honestly am leaving that to all of the professionals who, my goal here is to make this accessible to anyone of any economic situation. Yes, the donations do support our program, and we could not do this without the donations. But, you know, again, my goal is to make this minimally accessible to the patients that need it. And I think this is what should be done in human populations as well. Yeah. And we hope to get there as well.
Yes.
So, boy, you asked a question I just can't answer. I'm sorry. About the cost of this therapy.
Well, in terms of impact of human cancer treatments, what do you think is going to happen, or what are you planning to do?
Well, I hope to get into human clinical trials in the coming years. Again, my original goal was to really do a limited canine therapy trial and then move quickly into human trials. But the canine work has gone so well, and I honestly believe that it has such value that I cannot leave this alone. I have to see this to the end. I really do. I have to use all of the energies of my group and collaborators and myself to move this forward as a canine therapy. Yes. And then once hopefully we're in tens of thousands of animals, is that will provide a lot of data in going into humans.
Yes.
You know, so, and this has been done with a few other therapies over the years as well, is in both directions. We know about a lot of chemotherapies because of how they worked in humans. We then directly applied them to canine cancers. In fact, many, not all, there's a few chemotherapies that have been developed specifically for dogs, but most of them have been first developed for humans and then applied to dogs.
Yes, in Seattle, we have Fred Hutch Cancer Research Center, and that's where the original work was done with dogs with stem cell transplants. Of course, that's saving lots of lives today. But ultimately, we do not want to see dogs used as stepping stones to curing cancer in humans. We would like to see dogs cured
It's my goal.
Yeah.
My goal.
Excellent.
I don't want my dogs, my future dogs, to suffer, nor
No,
anyone
we
else.
don't.
Yeah,
No, I have 3 dogs and they're all golden retrievers. And
yeah,
so we definitely want to see much better treatments.
yes,
So
yes.
you had mentioned that your vaccine does protect the dog from cancer spreading. So can you possibly see this as a prevention vaccine in the future?
Uh,
So
Another great question. Yes, we're now, since we're now 4 years into the program, we can now begin to measure how robust, how stable the anti-tumor response is over many years in some of our early patients that have survived. So in many cases, the antibodies do persist for a long period of time, well over a year,
mhm,
and in many cases over 2 years. Will they exist after 6, 8, or 10 years in a
mm,
particular dog that may be vaccinated as a 1 or 2-year-old? That we would love to know. We're trying to first solve the cancers that exist. But you bring up literally the $1 million question, which is, would or should this be a healthy dog vaccination that may prevent cancers in the future? The only therapy that exists for is in humans, which is HPV,
mhm,
human papillomavirus, for which
mhm,
it's a viral vaccine that prevents cancers in HPV initiated cancers in humans before they occur,
mhm,
presumably.
mhm.
So the rationale is good, and the HPV vaccine is a healthy human vaccine. Whether this should or could be a healthy dog vaccine, we hope to know that once we're out there and hopefully helping to cure cancer-bearing dogs, we'll get to the healthy dog, stage as well.
Good.
Stay tuned, Mari.
Okay. Well, it sounds like you have a lot on your plate.
Yeah.
You're very busy, and I'm so, so appreciative of you taking the time to talk to us today. Thank you so much.
Thank you for having me.